we might be surprised to hear this, but for many people dealing with a wound, what bothers them most isn't always, the wound itself, it's the pain.
Yeah, it's true. In fact, studies show patients often rate their wound pain as their top concern, sometimes even more than the healing process itself.
Okay, let's unpack this because this deep dive is laser focused on understanding wound pain, something incredibly common, but often overlooked in its complexity.
It's a real eye-opener when you see that disconnect, right, between what patients are actually going through and what healthcare sometimes prioritizes. This deep dive into the pain management chapter of Wound Care Essentials,
Mhm.
Practice Principles by Wu and Sibold, is going to shed some light on why that pain is such a big deal.
Exactly. Think of this as your express road to getting a solid handle on wound pain. We're
Hmm.
pulling out the most important stuff, what it is, the different kinds, how we figure out how bad it is, and, most importantly, what we can actually do about it. And this isn't just for doctors and nurses. If you're helping care for someone with a wound, or even if you just want to understand this better yourself, this is for you.
And it's worth knowing that we're getting this information from a really reliable source. Wound Care Essentials, Practice Principles, now in its fifth edition by Baranowski and Aiello, it's a go-to resource in wound care.
Right.
And the folks who wrote the pain chapter, Dr. Wu and Dr. Sibold, are experts in the field, so we know we're talking about solid, evidence-based stuff here.
So our goal for this deep dive is simple: to extract the most vital insights about wound pain from this expert source and make it clear and easy for you to understand. Let's jump right in.
Okay.
First things first, when someone says they're in pain from a wound, what exactly are they experiencing? What are we talking about?
Well, the chapter starts by giving us a clear picture of what pain actually is, based on how the experts define it. Groups like the International Association for the Study of Pain and the Agency for Healthcare Research and Quality tell us that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage.
Sensory and emotional, that's key.
Exactly, or described in terms of such damage. The important thing to notice here is that it's not just a physical feeling, there's that emotional side to it, too.
Right. It's not just a signal from the body. It
Yep.
affects how you feel overall. And then there's that really, really important way of thinking about it from McCaffrey and colleagues.
Absolutely. They said, and this is crucial, pain is whatever the experiencing person says it is and exists whenever she says it does.
Wow. That's powerful.
It is huge because
Yeah.
it puts the person experiencing the pain right at the center of the assessment. You can't just look at someone and know how much they hurt. You have to listen to them.
Which leads to a crucial takeaway from the chapter,
Yeah.
a real practice point. Pain is what the person says it is.
Yeah.
It sounds straightforward, but it's probably the most important thing to remember when dealing with someone in pain.
It really is fundamental. And it's interesting how this plays out in practice, actually. The chapter mentions a study in Australia
Oh, yeah.
that found nurses were much more likely than podiatrists to check on wound pain during dressing changes and, importantly, to use proper pain assessment tools.
That's interesting. So it suggests that how much we focus on pain assessment can really depend on our role in healthcare.
It seems like it, yeah. Or maybe the training or context, it's something to think about.
Okay, so pain is personal. It's subjective.
Hmm.
Now, what are the different kinds of pain someone with a wound might have? The chapter talks about two main types.
That's right. We have nociceptive and neuropathic pain. And often, wound pain actually involves a mix of both.
Okay, let's start with nociceptive. What's that?
Nociceptive pain is basically your body's normal pain response to something that's hurting it. The ongoing activation of nerve fibers because of tissue damage or potential damage.
Right, like hitting your thumb with a hammer, that immediate localized ouch feeling.
Exactly. And there are different flavors of nociceptive pain, right? Somatic and visceral.
Mm-hmm.
Exactly. Somatic pain comes from things like your skin, bones, muscles, the stuff sort of on the outside, or the body wall. It's usually pretty easy to pinpoint where it hurts.
Okay.
It might feel like aching or throbbing.
Yeah.
Pain from a pressure ulcer is often a good example of somatic pain.
Gotcha. And visceral.
Visceral pain is different. It comes from your internal organs, and it's often harder to locate, sometimes feeling more like cramping or squeezing.
Okay.
The relatively good news is that both of these types of pain usually respond pretty well to standard pain relievers, both the non-opioid ones like acetaminophen or NSAIDs and opioids.
Got it. So nociceptive is the something is damaged pain signal. Now, neuropathic pain sounds more complicated.
It is, generally speaking. Neuropathic pain happens because there's been some kind of damage or dysfunction within the nervous system itself, either the peripheral nerves in your arms and legs or even the central nervous system, the brain and spinal cord.
So the wiring itself is affected.
Precisely. The chapter mentions a study on leg ulcer pain by Taverner, Kloss, and Briggs that showed how pain can sometimes evolve. It can start as acute nociceptive pain, then become persistent with both nociceptive and neuropathic features, they call it wind-up, and eventually become sort of refractory, really hard to treat.
Interesting. So it can actually change over time if it's not dealt with properly.
It seems so. And the way neuropathic pain feels is often quite different. People frequently describe it as burning, stabbing, stinging, shooting, or even like electric shocks.
Ooh.
Things like the pain from a diabetic foot ulcer that affects the nerves, or, the pain after shingles that can often be neuropathic.
Those descriptions sound really, really unpleasant.
Yeah.
And the chapter points out that this kind of pain often needs different treatments, right?
Exactly. Your standard pain pills don't always cut it with neuropathic pain. Instead, doctors often use what are called adjuvant agents.
Adjuvant. What does that mean?
They're basically medications that weren't originally designed for pain but have been found to help in these nerve-related pain conditions. These can include certain antidepressants like TCAs or SNRIs and anti-seizure medications like gabapentin or pregabalin.
Okay, so different tools for a different problem.
Right. The chapter explains a bit about how some of these work, like how certain antidepressants can affect nerve signaling pathways, or how medications like gabapentin can sort of calm down overactive nerves.
Mm-hmm.
It also wisely reminds us that these medications can have side effects and need to be used carefully, sometimes with dose adjustments, especially if someone has, say, kidney problems.
Right, always important.
And yeah, the chapter even mentions that experts published guidelines back in 2014 outlining first, second, third, and even fourth-line treatments specifically for neuropathic pain. Things like gabapentinoids and certain antidepressants first, then maybe tramadol or specific opioids, then even cannabinoids or botulinum toxin in some cases.
So it's really about targeting the nerve issue, not just the general feeling of pain. Now, the chapter also talks about acute versus chronic pain, or, as the American Geriatric Society refers, persistent pain. Why the different word there?
Yeah, that's a good point. The American Geriatric Society prefers persistent pain, partly because the word chronic can sometimes carry, negative baggage. It might make people think of long-term untreatable conditions or even imply psychological issues sometimes.
I see.
Persistent is just more neutral. It focuses on the fact that the pain is ongoing, it's continuing. Acute pain, on the other hand, is that short-term pain that comes on suddenly from a clear cause, like a new injury or surgery. It usually resolves as the tissue heals. Persistent pain, though, sticks around for 3 months or longer, and it can really, really impact someone's daily life, their function, their emotional well-being. It can fluctuate, too.
And it's important to remember that in wound care, it's not always strictly one or the other, is it?
Absolutely not. Someone can have a new acute pain flare-up right on top of their underlying persistent wound pain. And like we said, you can easily have both nociceptive and neuropathic pain happening at the same time in a single wound.
That makes sense.
And things like inflammation, infection, or even local tissue ischemia, poor blood flow, can really compound the pain. The chapter really stresses that pain isn't just a physical sensation. It deeply affects sleep, appetite, how well someone can move around, and their overall psychosocial well-being.
And there are a couple more key takeaways here, practice points. Instead of saying a patient complains of pain, we should try to say they report pain.
Yes, that's much more respectful.
It is, isn't it? It validates their experience.
Yeah.
And using persistent instead of chronic can help shift how we think about and approach that long-term pain.
Definitely. It reframes it slightly.
Now, the chapter goes on to discuss Krasner's model of the chronic wound pain experience. What's that all about?
Krasner's model is really helpful for understanding the different patterns of ongoing pain that people with chronic or persistent wounds often experience. She identified 3 main types based on timing and triggers.
Okay, what are they?
First, there's non-cyclic, sometimes called incident pain. That's pain that happens at a specific, predictable time, usually linked to a procedure. Think sharp debridement or maybe even just moving someone.
Right, like during a dressing change?
Exactly, that's a common one. Second, there's cyclic or episodic pain. This is pain that comes and goes, often related to repeated treatments or activities like the pain you might feel every time a dressing needs changing, or maybe when you have to reposition someone regularly.
So it's predictable but happens repeatedly.
And finally, there's chronic or continuous pain, which, using the preferred term, we'd call persistent pain. This is the pain that's there pretty much all the time, even when the person is at rest, and nothing specific is being done to the wound. It might be a constant throbbing or aching.
Okay, so it's not just one steady level of pain. It can have these different triggers and patterns. And for each of these types, the chapter gives specific advice on what to do. Let's start with that non-cyclic incident pain, the kind that flares up during procedures.
Yeah, for pain related to procedures like cleaning the wound or removing dead tissue debridement, the chapter emphasizes having a pain management plan beforehand.
Well, active, okay.
Exactly. This might include using topical anesthetics, numbing creams or gels, or even local anesthetic injections. For really large or deep wounds needing extensive cleaning, they might even consider doing it in an operating room under anesthesia.
Makes sense for major procedures.
And giving pain medication, both regular non-opioids and maybe opioids, before and after the procedure is key. Plus, you need to assess how well the pain is being controlled during and after. The chapter also strongly advises against those old-fashioned wet-to-dry dressings.
Oh, those, yeah.
Because ripping them off can be incredibly painful. It suggests looking at gentler alternatives for cleaning the wound, like maybe enzymatic debriding agents or autolytic debridement with moist dressings.
Okay, that makes sense.
Okay.
Plan ahead for the painful parts. Be gentle. Now, what about the cyclic pain, the kind that happens with regular treatments like dressing changes?
Here, the focus is really on making those routine procedures as comfortable as absolutely possible. The chapter suggests things like scheduling them when the person feels less fatigued, if possible.
Good idea.
Giving pain medication well in advance, maybe 30 to 60 minutes before starting, is crucial. And again, assessing their pain levels before, during, and after the procedure. If a dressing has dried out and stuck to the wound bed, it should be soaked, usually with saline, to loosen it gently before removal. Don't just pull.
Please don't.
Exactly. Gentle cleansing is important, avoiding harsh chemicals like hydrogen peroxide or povidone iodine that can actually damage healing tissue. Don't pack the wound too tightly. Protect the surrounding skin, the peri-wound. Try to minimize how often dressings need changing, perhaps by using dressings that can handle more exudate or last longer.
Okay.
And definitely select dressings designed to reduce pain, maybe those with soft silicone adhesives or hydrogels. Avoid aggressive adhesive tapes, especially on fragile skin. Things like splinting or immobilizing the area might help, as can using pressure-reducing cushions or mattresses, and of course ensuring they have adequate analgesia for positioning changes and just generally avoiding trauma to fragile skin.
It sounds like a lot of it comes down to being thoughtful, gentle, and planning ahead to minimize any predictable discomfort.
That's a great summary of it.
And finally, what about that persistent background pain? The one that's there even at rest? How do we tackle that?
Managing persistent pain really builds on all those other strategies for non-cyclic and cyclic pain. The chapter stresses the need to address underlying factors that might be contributing, like controlling edema or swelling, and managing any infection effectively.
Right. Treat the cause.
Exactly. Keep monitoring pain levels even when the person is just resting. And critically, provide pain medication on a regular, scheduled basis, not just waiting for the pain to get bad. This could involve long-acting opioids, maybe patient-controlled analgesia, PCA pumps in some settings, or even topical lidocaine patches, depending on the pain severity and type.
Scheduled dosing, that's important.
Very important. And it's also crucial to think about other pain they might be experiencing, maybe from comorbid conditions like arthritis or even iatrogenic pain, pain caused by treatments themselves. And don't forget the emotional component. We need to address how the wound and the persistent pain are affecting their mood, their function, their body image, their whole sense of self.
It's a really holistic approach, isn't it? Recognizing that wound pain isn't just one simple thing, it's layered. Now, the chapter moves on to talk about how pain can be different depending on the specific kind of wound someone has. Which makes sense, right? Different wounds affect different tissues, have different causes.
Exactly. The chapter explains that pain can be generalized, sort of spread out or regionalized, related to the underlying cause, like poor circulation, or very localized, maybe just related to touching the wound, or a specific treatment or infection. Gardner and France actually linked increased pain specifically to infection.
Okay, so let's start by looking at pain from pressure injuries.
Right.
Those wounds that can develop from prolonged pressure, often over bony areas.
Right. Pressure injuries, formerly called pressure ulcers. The chapter acknowledges that even though they're a huge problem, there hasn't been as much dedicated research specifically on the pain associated with them as you might expect.
Really? That's surprising.
It is a bit, but clinicians definitely know it's a real and significant issue. The National Pressure Injury Advisory Panel, NPIAP, recognized way back in the late 80s that these injuries cause considerable pain, suffering, and disability.
So it's been known for a while.
Yes, and later on, experts like Van Ryswyk and Braden reaffirmed how vital pain assessment is for these wounds. They even proposed rewriting assessment guidelines based on the use of newer, moisture-retentive dressings, suggesting these might actually help reduce pain compared to older methods.
Interesting. And what are some of the potential reasons why pressure injuries can be painful?
Piper suggested several possibilities. It could be from noxious chemicals released by the damaged tissue itself, or from the destruction or subsequent regeneration of nerve terminals in the area. Infection is a big one. The dressing changes themselves, debridement procedures.
Right.
In deeper stage injuries, ischemic necrosis tissue death due to lack of blood flow can be very painful. Even in superficial injuries, things like excess moisture or friction on the skin surface can cause pain.
The chapter talks about a study by Cizors and Bourguignon that really highlights how common pain is with pressure injuries.
Yes, that study found that most patients with pressure injuries reported pain, both during dressing changes and even when they were just resting. And the pain intensity wasn't trivial. It ranged from just being sore to, in their words, excruciating.
Wow.
This really underscores why meticulous pain control is needed, using maybe long-acting meds plus breakthrough doses, and being incredibly careful to minimize wound surface pain during care.
And it sounds like researchers are still learning more. Piper and colleagues in an NPIA position paper highlighted findings about dressings that minimize pain, but also noted gaps in research, especially for certain special populations.
Right, and Langemo and Black published a white paper specifically focusing on assessing, preventing, and treating pain related to pressure injuries in palliative and end-of-life care settings, recognizing that their needs might be unique.
Okay, moving on to pain from arterial and lower limb ulcers, including diabetic foot ulcers. The chapter describes a different kind of pain here, often related to blood flow issues, right?
Right. This is often about ischemia, lack of oxygen getting to the tissues. Pain can happen because the muscles aren't getting enough blood during activity, like walking. That's called intermittent claudication. It often feels like cramping, burning, or aching in the calf or thigh.
Okay.
Or, in more severe arterial disease, there can be rest pain. This is pain that occurs even without activity, and it often feels worse at night when the legs are elevated in bed because gravity isn't helping pull blood down. Interestingly, not everyone with peripheral artery disease gets that classic claudication pain. Sometimes it's just a more vague, atypical leg pain in the early stages.
And what can people do to help with this type of ischemic pain?
Well, the chapter points out that addressing the underlying vascular risk factors is crucial. This means things like smoking cessation, absolutely vital regular exercise programs, which can help build collateral circulation, weight loss if needed, and treating conditions like hypertension and hyperlipidemia.
Lifestyle changes are key.
Definitely. For that severe rest pain, which can feel like burning or numbness and gets worse with elevation, it's often constant and intense, and standard pain meds might not relieve it well. Sometimes just dangling the legs over the side of the bed can bring some temporary relief by improving blood flow.
Simple, but maybe effective.
Yeah. It's worth noting, as Newburn pointed out, that we don't always have great validated tools specifically for measuring pain and quality of life in people with diabetic foot ulcers, and that pain, along with other symptoms, can significantly impact their quality of life and potentially slow down healing.
Now, venous ulcer pain, that has its own set of potential causes, doesn't it? These ulcers are usually caused by problems with blood flowing out of the legs, leading to pooling and pressure.
Yes, venous ulcer pain can stem from several things. The edema or swelling itself can cause an aching feeling. There can be inflammation of the surrounding tissues, especially if there's woody fibrosis or lepodermatosclerosis, that hardening of the tissue you sometimes see. Bacterial contamination or infection in the wound can certainly cause pain, and sometimes there can be inflammation of the veins themselves called phlebitis.
So, a few different sources. How does it typically feel?
It can vary quite a bit. It might be just a mildly annoying ache, or it can be a really sharp, deep muscle pain. It often gets worse towards the end of the day because gravity causes more fluid to pool in the legs, that dependent edema. Standing or sitting for long periods, especially with legs crossed, tends to aggravate it.
Because the blood isn't returning properly.
Exactly. That's the underlying pathophysiology-reduced venous return.
And what are some things people can do to ease this venous ulcer pain?
Leg elevation is key whenever possible. Wearing compression stockings or bandages is fundamental to managing venous disease and reducing edema and pain. Avoiding prolonged sitting or standing, weight reduction if overweight, and smoking cessation are also important.
So managing the underlying venous insufficiency.
Precisely. The chapter also distinguishes between superficial phlebitis, localized tenderness and redness over a vein, sometimes treated with topical NSAIDs, and deep thrombophlebitis, or DVT, which is more serious, involves more diffuse pain and deep swelling, and carries a risk of pulmonary embolism.
Okay.
It also mentions that an increased bacterial burden in the wound, sometimes indicated by the Nerdis criteria, non-healing, exudate, red friable tissue, debris, smell, can lead to increased pain and delayed healing. And that inflammation associated with woody fibrosis and lipodermatosclerosis can be quite painful too.
And it mentions mixed ulcers.
Yes. Wu and Marin found that people with mixed arteriovenous ulcers tend to have lower quality of life, more mobility issues, and commonly experience moderate to severe pain. So that combination can be particularly challenging.
Neuropathic ulcer pain, which we touched on earlier when discussing pain types, is also really common in people with diabetes, isn't it?
Absolutely. Diabetic neuropathy is a very frequent complication. The pain associated with it often depends on the severity of the nerve damage and can be spontaneous. It doesn't necessarily need a trigger.
How do people describe that typically?
The sensations can be varied and quite strange sometimes. They might feel like the foot is asleep, pins and needles, burning, stinging, stabbing, shooting pains. Some experience allodynia, where even light touch is painful. Itching can also be a neuropathic symptom. Relief for this type of pain is primarily pharmacologic, using those adjuvant agents we discussed. The chapter makes a really important clinical point. If someone with known neuropathy, especially in the feet, suddenly develops new or excessive pain in that limb, it could be a warning sign. It might indicate an infection brewing, or possibly Charcot joint change is a serious bone and joint condition.
So new pain in a numb foot is a red flag.
Definitely. It also explains that after maybe 10-15 years of diabetes, or sometimes sooner with poor glucose control, many people lose that protective sensation in their feet. This means they might not feel a sharp object or injury, which is why sharp debridement can sometimes be done painlessly. However, if they do feel deeper pain, it could indicate structural disruption.
Like what?
Like, if there's pain deep within a foot ulcer, you need to check for osteomyelitis, a bone infection. Or if the foot becomes tender, swollen, and warm, even without an open ulcer, you should suspect Charcot foot.
So there's another key practice point here for clinicians.
Yes. It emphasizes differentiating true neuropathic pain from pain caused by vascular disease or infection in people with diabetes. And crucially, remember that pain developing in a previously painless neuropathic foot suggests a deeper, potentially serious issue like osteomyelitis or Charcot arthropathy.
Okay. The chapter also briefly covers pain associated with burns and skin graft donor sites.
Right. For pediatric burns, it mentions the comfort behavioral scale, which assesses things like alertness, calmness, crying, movement, muscle tone, and facial tension to gauge pain levels in children who might not be able to self-report accurately.
Useful tool.
And it highlights that untreated burn pain poses significant risks. Burn pain management needs to be comprehensive, often requiring supplemental strategies like regional anesthesia or even things like virtual reality to manage background pain, procedural pain during dressing changes, and post-operative pain.
And for skin graft donor sites.
Yeah.
Those can be notoriously painful.
They can be. The chapter mentions novel approaches being used, like continuous infusion or injections of local anesthetics using ice packs, topical numbing agents like lidocaine, and specific types of dressings like hydrocolloids or polyurethane films combined with fibrin sealants to minimize pain.
And lastly, it touches on pain associated with hidradenitis suppurativa, or HS.
Yes, HS is that chronic inflammatory condition affecting hair follicles, usually in areas like the armpits, groin, and under the breasts. It can significantly impact quality of life due to recurrent painful lesions, abscesses, and drainage.
How is the pain managed typically?
The chapter summarizes a stepped approach. It often starts with topical antiseptics like chlorhexidine wash and maybe topical antibiotics like clindamycin combined with benzoyl peroxide. Oral antibiotics, particularly tetracyclines, are often used. For pain relief itself, acetaminophen and NSAIDs are first line.
If that's not enough.
For more resistant pain, oral medications targeting neuropathic pain mechanisms might be tried, like TCAs, gabapentin, pregabalin, duloxetine, or venlafaxine. Opioids might be needed in severe cases. Topical treatments like superabsorbent dressings to manage drainage, ice packs, and even topical NSAIDs or lidocaine might offer some relief too.
It's clear that the type of wound really influences the kind of pain experienced and often the treatment approach. The chapter then shifts gears a bit to talk about our overall understanding of wound pain.
Yeah, it points out that historically, a lot of what we understood about wound pain was actually extrapolated from research on pain in other diseases like cancer or arthritis.
So wound pain itself wasn't always the primary focus.
Not as much as perhaps it should have been. However, there's definitely a growing recognition now that wound-associated pain is a major issue in its own right, significantly affecting patients.
And that's reflected in international efforts.
Absolutely. The fact that major international wound care organizations like the European Wound Management Association, EWMA, and the World Union of Wound Healing Societies, WUWHS, as well as burn societies, have developed specific consensus statements and guidelines on managing pain, particularly during dressing changes, really shows how important this is becoming on a global scale.
And what are some of the key things these international guidelines have highlighted? What did they find?
Well, for instance, an EWMA survey found that pain prevention is actually a top consideration for clinicians when planning a dressing change. That's progress. They also found that leg ulcer pain is often reported as the most severe type of wound pain, and interestingly, that the act of removing the old dressing is frequently the most painful part of the entire procedure.
That makes sense, especially if it's stuck.
Exactly. The WWHS document goes further, outlining common challenges in managing wound pain, addressing some persistent myths like the idea that pain is just something patients have to tolerate, and offering very practical interventions. The chapter refers to tables summarizing these, which would be useful for clinicians.
It's good to see this global effort and consensus building to improve how we handle wound pain. Now, the chapter takes a closer look at research that's specifically been done on pain related to pressure injuries. What did we learn there?
Yes, it examines studies from two perspectives: how nurses manage this pain and what the experience is actually like for the patients themselves.
Okay, what about the nursing management side?
Well, some research, like Hollingworth's study mentioned, suggested that nurses didn't always adequately assess, manage, or document the pain that patients experienced after a dressing change for a pressure injury.
A gap there.
Potentially. And another interesting qualitative study by Krasner identified 3 different patterns in how nurses approached patient pain. There was nursing expertly, where nurses were really attuned to the patient, reading cues, acknowledging pain. Then there was denying pain, where maybe they assumed it didn't exist or didn't hear the reports, perhaps to avoid feeling like they were failing. And finally, confronting the challenge, which involved coping strategies and just being with the patient through the pain.
That's fascinating. Understanding those patterns could help improve care, couldn't it?
Absolutely. It provides insight for reflection and potentially improving patient-centered approaches.
What have we learned from research about what it's actually like for patients with pressure injuries who are in pain? It sounds like maybe there haven't been as many studies on this as you might think.
That's true. The chapter notes the number of studies, particularly quantitative ones, has been somewhat limited. But the studies that have been done give us some really valuable insights.
Like what?
For example, Wu found a direct relationship between how anxious someone was about their pain and how intense the pain they actually experienced felt. People who felt less secure seemed more susceptible to this anxiety pain link.
So psychological factors play a big role.
Definitely. And Upton and colleagues linked stress and pain experienced during dressing changes to potentially delayed wound healing. They even documented specific tools that can be used to assess stress levels in this context.
Wow, stress affecting healing. What else?
A study by Dahlem and colleagues actually quantified pain according to the stage of the pressure injury. They also compared 2 pain scales, the Visual Analog Scale, VAS, and the FACES Pain Rating Scale, FPRS, and found good agreement, but noted the FACES scale might be easier for people with cognitive impairments or language barriers.
Okay, and what were their key findings about the pain itself?
Several important things came out of Dahlem's study. First, the vast majority of patients did have pain. Second, most of them, shockingly, only about 2%, didn't receive any analgesics for it.
Only 2%.
Yeah, concerning. They also found that deeper stage injuries tended to be associated with more pain. Certain treatments, like surgical debridement or those wet-to-dry dressings, seemed potentially linked to increased pain, while static air mattresses and hydrocolloid dressings were associated with less pain.
That's useful practical information.
It is. They also confirm that patients can usually differentiate pain at the wound site from other pain, and importantly, that even some patients with cognitive impairment can indicate the presence of pain if assessed appropriately.
So the big takeaway from Dallam, and also SARS and Bourguignon, seems to be that pressure injury pain is common, but often underreported and undertreated.
That's the clear message, yes, a stark reminder.
It's interesting that one UK study by Franks and Collier actually found something paradoxical.
Hmm.
Less pain reported by home care patients with pressure injuries compared to similar patients without them. That seems counterintuitive.
It does on the surface. The researchers speculated a bit. Maybe the patients with pressure injuries had different underlying health problems, or perhaps counterintuitively, the presence of the wound meant their pain was actually being more effectively managed at home compared to similar patients whose pain wasn't linked to an obvious wound. It's hard to say for sure.
And other research by Aiello and colleagues confirmed that pain prevalence varies by wound type, right?
Yes, they found venous ulcers tended to be reported as more painful than diabetic foot ulcers or pressure ulcers in their study population.
And studies that have really listened to patients describe their pain qualitatively paint a very vivid picture, don't they?
Oh, absolutely. Langemo and colleagues did qualitative work capturing powerful themes. Patients talked about the perceived cause of their pain, the devastating impact it had on their lives functionally, socially, emotionally, even spiritually. They used incredibly strong words to describe the intensity: burning, stabbed like needles, stinging. They expressed a deep need for knowledge and understanding about their pain, the stress associated with treatments, a sense of grieving losses, the fear that the pain would persist even after healing, and significantly, a fear of becoming addicted to analgesics.
That fear of addiction comes up again.
It does. And Ristine study found that lack of communication from healthcare providers and undergoing painful treatments were common complaints. Hopkins and colleagues in a European study focused on older patients with severe pressure injuries and described this theme of endless pain.
Endless pain.
Yeah, with sub-themes like the pain being constantly present, the pain of trying to keep still, pain caused by equipment like mattresses or chairs, pain from treatments, and just really graphic descriptions of the suffering.
It's heartbreaking, really.
It is. The consistent message cutting across all these chronic wound studies is the urgent need for adequate pain assessment and effective treatment. We have to do better.
That leads us directly then to the crucial step of pain assessment. The chapter emphasizes that even though pain is often called the fifth vital sign, it's still not always routinely assessed, particularly in people with pressure ulcers.
That's a real persistent problem. Experts like Dallam and colleagues strongly urge clinicians to add pain assessment both at rest and during dressing changes to the standard wound assessment protocol. And crucially, they remind us that just because someone doesn't respond or complain doesn't mean they aren't experiencing pain.
Especially if they have communication difficulties.
Exactly. And research we mentioned earlier by Aiello et al. Showed that pain assessment was documented less frequently for pressure injuries compared to other wound types like venous or diabetic ulcers, so there's inconsistency.
The chapter mentions some specific assessment guides that incorporate pain.
Yes, some older guidelines from AHCPR back in '94 included a simple yes-no question about pain. More recently, Aiello developed the assessment mnemonic tool for wound assessment, which specifically prompts checking for the presence of pain, its timing, what relieves it, and whether there's tenderness to touch or pain only during care.
Okay, more structured prompts.
And there's also the widely used PQRST mnemonic, which provides a framework for a more detailed pain assessment. P for provokes palliates, Q for quality, R for radiates region, S for severity, and T for timing. The chapter refers to a table detailing this.
PQRST, yeah, that's common.
The point is that a thorough assessment using these kinds of tools is the absolute foundation for planning effective treatment and then evaluating whether that treatment is actually working. The chapter also points to resources from groups like the American Society for Pain Management Nursing for assessing pain in nonverbal patients, folks with dementia, infants, people who are intubated or unconscious. And the Hartford Institute for Geriatric Nursing has helpful guides too.
And another key practice point reminder here, pain is the fifth vital sign. It needs to be assessed just like temperature, pulse, breathing rate, and blood pressure.
Absolutely fundamental.
Now, once we've established the pain is present, how do we actually measure how intense it is? That's where pain intensity scales come in.
Exactly. Pain intensity scales give us a way to quantify the pain. Put a number or a description on it using verbal reports, visual aids, or numeric ratings. Asking the person themselves using a standardized instrument is considered the gold standard, the most reliable way to measure their pain.
So self-report is key.
Self-report is paramount. These scales primarily measure the sensory dimension of pain, how strong it feels, and using them is often mandated in hospital settings by organizations like the Joint Commission.
Okay. The chapter highlights two very common scales: the numeric pain intensity scale and the FACES pain rating scale. Let's start with the numeric scale, the 0 to 10 one.
Right. The Numeric Pain Intensity Scale, or NPIS, is often considered the gold standard for adults and children over about 7 years old who can understand numbers. It's typically presented as a scale from 0 to 10, where 0 means absolutely no pain, and 10 represents the worst pain imaginable or the worst pain they've ever felt.
Simple concept.
Yeah. Patients just pick the number that best reflects their current pain level. It can be helpful to provide anchors or examples like maybe a 2 is a dull ache, a 5 is like slamming your finger in a door, a 10 is unbearable. It can be presented verbally or visually, and it's been translated into many languages. Its main role is guiding medication choices and assessing if interventions are actually reducing the pain score.
Okay. And the other common one is the FACES pain rating scale. How does that work?
The FACES scale, often the Wong-Bicker FACES scale, uses a series of 6 cartoon faces. They range from a very happy face, representing no pain or no hurt for kids, to a crying distress face, representing the worst pain. Each face is typically assigned a number, often 0 to 5 or 0, 2, 4, 6, 8, 10.
So it's more visual.
Exactly. Patients just choose the face that best matches how they are feeling. It was originally developed for children, but it can also be useful for adults who have difficulty with numbers, maybe due to cognitive impairment, or for those who speak a different language. Some suggest using the word ache instead of hurt might be better for older adults.
Is it as reliable in adults?
Its validity in adults isn't quite as established as the numeric scale, but studies have shown decent agreement with other scales in geriatric populations. One potential limitation is that the faces might not always be culturally or gender appropriate for everyone.
Good point. So regardless of which scale is used, the key is using something standardized and reassessing regularly, right? After the initial assessment and after any interventions are made.
Precisely. Consistent assessment and reassessment are crucial for effective management.
So consistent and accurate assessment is the starting point. Now we can finally move on to actually managing the pain. The chapter really stresses that good pain management absolutely depends on that initial, thorough assessment.
It does. As McCaffrey and Robinson stated, accurate and continuous assessment is the foundation. Yet, as we've discussed, evidence shows assessment is often poorly done. The chapter mentions barriers like clinicians' own knowledge or familiarity with tools, and even studies showing physicians under-inquiring about severe pain.
So even when tools are available, they aren't always used effectively.
Right. Using assessment measures definitely improves management, but challenges remain and ongoing training is needed. But assuming we have identified and assessed the pain, the next step is to try and treat the underlying cause if possible.
Right, not just masks the symptom.
Exactly. The chapter quotes Bergstrom and colleagues emphasizing that pain treatment isn't just about medications. It also involves things like physical and occupational therapy, proper seating and positioning, using adaptive equipment. All these can help alleviate pain.
So a multi-pronged approach.
Definitely. And specifically for pressure injury pain, while more research is needed on the optimal treatment, the chapter highlights the importance of assessing the cause, addressing the patient's specific concerns, and ensuring that the local wound care itself is done in a way that minimizes pain at every step.
And there's another helpful practice point here, listing the key components of pain management interventions.
Yes, it's a great checklist. It includes treat the cause, address patient concerns, provide education, improve activities of daily living, ADLs, and quality of life, minimize pain and trauma during local care, assess and treat infection, provide palliation if cure is impossible, minimize adverse effects of treatments, and minimize patient dependency. It's a very comprehensive, patient-centered view.
Okay, now let's talk specifically about pain medication. The chapter introduces the World Health Organization's 3-step analgesic ladder, which is a pretty common framework.
Yes, the WHO ladder. It was originally developed for cancer pain back in the 80s, but it's been widely adopted and adapted for managing other types of acute and persistent pain, including wound pain.
How does it work, basically?
It's a stepped approach based on pain intensity. The idea is to start with the simplest, safest options and escalate only if needed. Step 1 is for mild pain. typically rated 1 to 3 on that 0-10 scale. It involves using non-opioid analgesics like acetaminophen or NSAIDs, sometimes with or without an adjuvant medication.
Okay, mild pain, non-opioids. What's step 2?
Step 2 is for moderate pain, maybe a 4 to 6 out of 10. If the step 1 meds aren't enough, you might add a weak opioid, often in combination products, or a low dose of a strong opioid, again, potentially with or without a non-opioid and/or an adjunct.
And step 3?
Step 3 is for severe pain, usually 7 to 10 out of 10. If step 2 isn't cutting it, you move to stronger opioids, often used regularly, potentially still combined with non-opioids or adjuvants.
You mentioned adjuvant medications again. Can you remind us what those are?
Sure. Adjuvant analgesics are medications whose primary indication isn't pain relief, but they've been found to be effective for certain types of pain, especially neuropathic pain. Common examples include certain antidepressants like tricyclics, TCAs, or SNRIs, and anticonvulsants like gabapentin or pregabalin.
Got it. And combining different types can be beneficial.
Yes, often combining an opioid with a non-opioid can provide better pain relief at lower doses of each, potentially reducing side effects. They work synergistically.
Let's break down that first step, non-opioid analgesics. What does the chapter recommend starting with?
For mild pain, acetaminophen, like Tylenol, and NSAIDs, like ibuprofen or naproxen, are usually the first line. The chapter recommends administering them on a regular schedule around the clock rather than just as needed to maintain a consistent level of pain relief.
Okay, regular dosing.
Yes. It mentions injectable acetaminophen is available if someone... The chapter mentions tricyclic antidepressants, TCAs, like amitriptyline or nortriptyline, can be effective for neuropathic pain, like postherpetic neuralgia, but they also have significant side effects, especially anticholinergic ones in older adults, and should be used cautiously starting at low doses, and are generally avoided in patients with coronary artery disease.
Right, TCAs have baggage.
They do. It also mentions hydroxyzine, which is a sedating antihistamine, can sometimes be used as an adjuvant, particularly to help with sleep if pain is disruptive. And anticonvulsants like gabapentin, pregabalin, and others are noted as useful for neuropathic pain in diabetics and other peripheral nerve syndromes.
Okay, so several non-opioid and adjuvant options for step 1. Now, moving on to opioids.
Yeah.
The chapter mentions they come in various forms, which are generally preferred.
For long-term persistent pain management, the oral route, pills or liquids, is usually preferred. It's convenient and generally effective. However, for managing acute pain, like before or after a painful procedure, intravenous opioids might allow for quicker onset and better dose titration.
And how should they be dosed for persistent pain?
The chapter emphasizes scheduled dosing, giving the medication regularly around the clock to maintain a steady level and prevent pain from breaking through. Short-acting, immediate-release opioids are then used for breakthrough pain episodes that occur despite the regular long-acting medication.
So a baseline dose plus rescue doses.
Exactly. It explains that sometimes patients experience an analgesic gap, where a long-acting opioid prescribed for every 12 hours doesn't quite last that long, and maybe an 8-hour interval is needed. Careful monitoring helps figure this out. The chapter also refers to a table showing examples of common combination opioid products, reminding us to watch the total daily dose of acetaminophen or NSAID in those.
Right, got to track that component too.
Sure.
Now, what about common opioid side effects? Constipation is a big one, isn't it?
Huge. The chapter stresses that constipation is an almost universal side effect of chronic opioid use and recommends proactive treatment. Don't wait for it to become a problem. Start stool softeners and potentially stimulant laxatives right along with the opioid, plus encourage fiber and fluids.
Proactive bowel regimen. Got it. What else?
Other common side effects include sedation or drowsiness, usually worse initially, nausea and vomiting, also often improves over time, itching, urinary retention, and occasionally some sensory or motor deficits, although those are less common.
And what about the really feared side effect, respiratory depression, problems with breathing?
The chapter addresses this directly. It states that clinically significant respiratory depression is actually uncommon when opioids are dosed appropriately and the patient is monitored properly. The risk is higher in patients with advanced disease, other comorbidities, or if doses are increased too quickly. But it can be minimized by starting with low initial doses, titrating upwards gradually, and careful monitoring, especially when starting or increasing doses.
Okay, so it's a risk, but manageable with care. Now, there's a significant section titled Evidence-Based Practice, Avoiding Addiction. This is clearly a major concern.
It absolutely is. The fear of addiction, both from patients and clinicians, can lead to underutilization of opioids and unnecessary suffering. Educating patients and caregivers, especially in home care, is crucial.
What does the evidence say about the actual risk?
The chapter states that the risk of developing true addiction, now often termed opioid use disorder, when opioids are used appropriately for acute pain, is actually quite low, around 1% or less in most studies.
That's much lower than many people probably think.
It is. However, it absolutely acknowledges the potential for abuse and misuse and the need for careful monitoring, especially in individuals with a personal or family history of non-opioid substance abuse or certain mental health disorders. The rising rates of prescription drug abuse are a serious public health concern.
And regulatory bodies are involved too.
Yes, it mentions the FDA's risk evaluation and mitigation strategy, HAM-ROMES, for extended release and long-acting opioids, which includes education for prescribers and specific labeling changes to promote safer use.
How can clinicians assess the risk?
The chapter recommends using validated screening tools like the Opioid Risk Tool, ORT, or the SOPR, before starting long-term opioid therapy to help identify patients at higher risk for problematic use.
And what's the sign that abuse might be developing?
A key indicator is craving the medication for reasons other than pain relief, for euphoria, to cope with stress, etc.
Okay. And there's a framework for monitoring ongoing opioid therapy.
Yes, it highlights the importance of assessing and documenting the 4As of opioid treatment regularly. Analgesia is the pain controlled. Activities of daily living is function improving. Adverse effects are side effects manageable. And aberrant behaviors, are there any signs of misuse or addiction?
4As. That's helpful. And there's a strong warning about one specific opioid.
Yes, a very strong warning against using meperidine Demerol for chronic pain management.
Why is that?
Because its metabolite, normeperidine, is toxic and can accumulate, especially in patients with kidney problems. This can cause CNS excitability, leading to tremors, seizures, hallucinations, coma, and even death. Plus, the oral form isn't even that effective as an analgesic, but still produces the toxic metabolite, so just avoid it for chronic pain.
Good to know. Avoid meperidine. Now, going back to the WHO ladder, step 2 involves opioids for mild to moderate pain. What are some examples if step 1 isn't enough?
This might involve using those combination opioids we mentioned, ones that contain codeine, hydrocodone, or oxycodone, combined with acetaminophen or an NSA, referring to table 12 to 8 in the text. Or, if NSAIDs are contraindicated, starting a low dose of a single-agent opioid like immediate-release oxycodone 5 mg could be considered. The chapter notes that propoxyphene, darvon was withdrawn from the market due to cardiac toxicity. And it mentions codeine can have a high rate of side effects for some people due to genetic variations in how it's metabolized.
Okay. And for step 2-3, moderate to severe pain. It sounds like this involves adding stronger opioids if the earlier steps aren't working.
Yes, if step 1 or mild step 2 approaches aren't providing sufficient relief for moderate to severe pain, the next step is typically adding or switching to stronger opioids like morphine or morphine-like agents, referring to table 12 to 9. Again, these are often used alongside the step 1 non-opioids or adjuvants, especially if there's a neuropathic component to the pain.
And always being mindful of side effects and interactions.
Absolutely. Prescribers and nurses need to be really aware of the potential side effects, drug interactions, and the increased risks associated with age or specific diseases.
The chapter includes a practice point with some really helpful practical hints for using opioids. What are some key takeaways there?
It covers several good points. It mentions that oral transmucosal fentanyl, like a lollipop or film, provides very rapid relief, but its use for things like dressing changes is technically off-label. It's FDA approved only for breakthrough cancer pain and should only be considered in patients already tolerant to opioids.
Okay, specialized use.
For fentanyl patches, it advises starting at the lowest dose, usually 12.5 or 25 mils each HR, in opioid-naive patients, monitoring them very carefully because the onset is slow, takes 12-24 hours for full effect, and often needing short-acting opioids initially and for breakthrough pain.
Good tips for fentanyl. What else?
It reiterates using short-acting agents for breakthrough pain, typically around 10-15% of the total daily long-acting dose. If a patient needs frequent breakthrough doses, it usually means the baseline long-acting dose needs to be increased.
Makes sense.
Proactively managing constipation with stool softeners and laxatives is stressed again. When tapering or discontinuing opioids, decrease the dose slowly, maybe by 25% every 2-3 days, monitoring for both returning pain and withdrawal symptoms.
Slow taper.
Yes. And it highlights morphine as often being a cost-effective first-choice opioid for chronic pain because it comes in various formulations, oral, injectable, rectal, is easily titratable, and its side effects are generally manageable. However, it should be avoided or used with extreme caution in significant renal disease, GFR30, due to accumulation of an active metabolite. Pain consultation is suggested if daily doses exceed the equivalent of 120 milligrams of oral morphine.
Good guideline there.
Finally, it mentions that research into topical opioids applied directly to painful skin ulcers is showing some promise, which is an interesting area to watch.
Topical opioids. Fascinating. It's clear that managing opioid pain relievers requires careful assessment, planning, and monitoring. Now, the chapter moves on to non-pharmacologic treatments, things that don't involve medication. It emphasizes that these should ideally be used alongside medication, not instead of, usually.
Absolutely. A multimodal approach is almost always best. Combining pharmacologic and non-pharmacologic strategies often yields better results and can sometimes allow for lower doses of medications.
What are some examples of these non-drug approaches?
The chapter lists quite a few. Things like music therapy, massage, relaxation techniques like deep breathing or guided imagery, simply allowing patients to have timeouts or pauses during painful procedures. Physical and occupational therapy are huge. Proper repositioning, using appropriate support surfaces like pressure-relieving mattresses, and optimizing the local wound care itself using pain-minimizing materials and techniques.
Lots of options there. There's another important practice point here reminding us about the symptoms of opioid withdrawal. Why is it important for clinicians to recognize these?
Yeah, it lists symptoms like tachycardia, fast heart rate, hypertension, insomnia, sweating, goosebump, piloerection, dilated pupils, nausea, diarrhea, abdominal pain, body aches, increased pain sensitivity, yawning, runny nose, and anxiety. It's crucial to know these because they don't necessarily mean the person is addicted. It might just be a sign that the opioid dose is being tapered down too quickly, causing physical dependence withdrawal.
Oh, it helps differentiate physical dependence from addiction.
Exactly, which is a really important distinction.
What specific non-drug therapies are highlighted in more detail?
Physical and occupational therapy, PTOT, are emphasized for their value in maintaining or improving function. They can teach passive and active range of motion exercises to prevent stiffness. For people with peripheral vascular disease, PVD, structured walking programs can actually help develop collateral circulation.
Exercise is medicine.
In a way, yes. 10NS, transcutaneous electrical nerve stimulation units, are mentioned as potentially helpful for reducing both chronic and acute wound pain, although evidence is mixed. Things like hot or cold packs can help with muscle spasms, stretching can help with contractures, and exercise or massage can relieve muscle tension related to guarding against pain.
And what about things we can do directly at the wound site, local pain management?
This is really key for procedural pain. The chapter stresses careful selection of dressings and techniques to ensure low pain changes. It references a survey by Moffitt et al., indicating that traditional gauze dressings were often perceived as the most painful to remove, while things like hydrogels, hydrofibers, alginates, and especially dressings with soft silicone adhesives were generally less painful.
So dressing choice matters a lot.
A huge amount. But even with the best product selection, if dressing changes remain uncomfortable, then pre-medication before the change is still essential. A benefit of modern moist wound dressings is that they often allow for longer wear times, which inherently means fewer painful dressing changes overall.
Fewer changes, less pain. Simple.
Pretty much. And there's that strong practice point again. Avoid wet to dry dressings. They desiccate the wound bed, stick, and remove viable tissue on removal, causing significant pain and trauma. Moisture-retentive dressings are the standard of care now. Other local interventions include ensuring good pressure redistribution, like keeping heels off the bed, controlling edema, and just generally eliminating other potential sources of pain or irritation around the wound.
Taking a patient-centered care approach seems to be the overarching theme in all of this.
It really is. There's another practice point that reinforces this. It reminds us that while pharmacologic treatment is the gold standard for moderate to severe pain, we need to give meds around the clock if pain is constant. Critically, we need to educate the patient and family about pain management, explain the plan, alleviate fears about addiction, and help them understand that controlling pain can actually aid healing.
Education is key.
Absolutely. The practice point then outlines specific steps for patient-centered dressing changes. Explain the procedure beforehand, allow the patient to choose the time if feasible, assess pain and premedicate before and reassess after, invite their participation if they wish, offer distractions, music, conversation, allow for timeouts if they need a break, ensure they're adequately rested, fatigue lowers pain threshold, teach substitutes for scratching if itching is an issue, instruct in relaxation or imagery techniques, constantly reevaluate the pain plan, document effectiveness using a pain score, and address those ancillary problems like loss of function or body image concern.
Wow, that's a comprehensive checklist for compassionate care.
It really covers all the bases for making a potentially unpleasant experience as tolerable as possible.
And finally, within local care, being careful with wound cleansing and dressing application is crucial.
Yes, another practice point emphasizes this. Assess pain even at rest. Use warm, normal saline or designated low-cider toxicity wound cleansers. Avoid harsh solutions like full-strength iodine, hydrogen peroxide, or Dakin's solution in most cases, as they can harm healing cells. Utilize moist wound therapy principles to promote autolytic debridement using the body's own enzymes. Change dressings appropriately if they become saturated or dry out. Pain can increase. Protect the peri-wound skin with barrier products. And avoid using strong adhesive tapes directly on fragile skin. Use gentler fixation methods.
So gentleness and appropriate materials are paramount. The chapter also briefly touches on some alternative pain management methods.
Right. These are generally complementary approaches, natural methods that can help relieve pain, stress, and anxiety, potentially enhancing the effects of conventional medications.
What kinds of things are mentioned?
Things like laughter promotes deeper breathing, can lower blood pressure, changes mood. Acupuncture is mentioned. Creating a comfortable environment, appropriate temperature, dim lights, quiet. Distraction techniques, as we discussed. Music therapy can increase blood flow, energy levels, maybe even endorphins. Magnets are mentioned as popular, particularly with athletes, with theories about cellular changes, though evidence is limited. And topical capsaicin, derived from chili peppers, which works by depleting nerve endings of substance P, initially causing burning but then reducing neuropathic pain.
Interesting options to consider alongside standard care. So to wrap up the main discussion before the case study, what are the absolute most important things to remember about wound pain management from this chapter?
I think there are a few key takeaways. First, using validated pain scales to get regular pain scores is incredibly useful for both assessing and effectively treating persistent wound pain. Second, we absolutely cannot underestimate the detrimental effects of poorly controlled pain. It impacts ADLs, self-worth, social interaction, sleep, appetite. It can delay wound healing and significantly diminishes overall quality of life and even quality of death in palliative situations.
Pain affects everything.
Everything. And finally, the concluding message is really a call to action for clinicians. We have an ethical obligation to provide adequate pain relief using appropriate pharmacologic and non-pharmacologic modalities for all patients experiencing wound-associated pain.
A powerful concluding thought. Now, the chapter really brings us all together with a detailed patient scenario featuring Mr. LK. Can you set the scene for us?
Sure. Mr. LK is a 67-year-old male, hospitalized with a painful infected leg ulcer. His pain is severe, rated 10 out of 10, both at rest and especially during dressing changes. He describes it as a deep aching with an unbearable burning sensation. He's quite distressed, feeling saddened and terrified, even comparing his wound experience to things his buddies went through in Vietnam.
Wow, that's intense pain and emotional distress. What's the story with his ulcer?
It's been worsening for about 9 months. It's on his lateral lower leg, measures 4 by 6 centimeters. The wound bed has some red, friable granulation tissue, but also yellowish, malodorous slough, indicating infection and non-viable tissue. There's surrounding cellulitis, skin infection, edema, signs of chronic venous changes like woody fibrosis, increased exudate, and odor. His pain is clearly affecting his ability to walk, sleep, and perform daily activities.
And what about his background?
He lives alone, is a Vietnam veteran. He used to smoke half a pack a day, but says he's cut down to 3-4 cigarettes. He mentions remote marijuana use, but denies other substance abuse. Importantly, he expresses a significant fear of becoming addicted to opioid pain medication. He occasionally drinks beer, no formal psychiatric history, but he talks about the pain of his soul. He's not on sleep meds or psych meds currently.
Okay, so psychosocial factors are definitely present. What about his medical history?
He has hypertension, hyperlipidemia, osteoarthritis, stage 3 chronic kidney disease, CKD, and a history of deep vein thrombosis, DVTs.
CKD is important for medication choices.
Mm-hmm.
And what pain meds has he tried?
He tried acetaminophen with codeine combined with plain acetaminophen, which gave him maybe 30% relief. He also tried tramadol, but became confused and stopped it. Currently, he's on short-acting morphine 15 milligrams as needed every 8 hours, which provides about 60% relief, but only for about 4 hours.
So clearly suboptimal pain control. What's the overall diagnosis?
Non-healing, painful, infected venous leg ulcer with associated cellulitis.
Okay, a complex picture. The discussion of Mr. Elke's case then outlines the initial steps for assessing and treating his pain, considering all these factors. What were the key rationales?
Well, first, given his stage 3 CKD, certain medications need caution. Codeine and morphine should generally be avoided or used very carefully due to the potential accumulation of active or toxic metabolites in kidney disease. NSAIDs also need caution due to renal risks.
Right, medication safety first.
Absolutely. The recommendation is clearly for a multimodal pain relief strategy combining both drug and non-drug approaches. And because of his explicitly stated fear of opioid addiction, patient education about risks, benefits, and alternatives is paramount. The goal should be to minimize opioid use if possible, and if opioids are necessary, use the lowest effective dose for the shortest duration necessary to achieve functional goals.
Makes sense. What non-drug strategies were implemented for Mr. Elke?
The focus was on treating the underlying problems contributing to pain, aggressive local wound care to manage the bioburden, infection, and exudate cleansing, promoting autolytic debridement. Systemic antibiotics were started for the cellulitis. Reducing infection and exudate often helps reduce pain directly.
Okay, treat the infection.
He was also advised to avoid prolonged sitting and to elevate his legs when sitting to manage the venous component. Smoking cessation was strongly encouraged. Care was taken to avoid wet-to-dry dressings or strong adhesive tapes. A Doppler study was done, which ruled out significant arterial disease, confirming the venous etiology.
Good to confirm.
And given his comments about pain of his soul, survival guilt, and sadness, he agreed to a psych evaluation to address these significant psychosocial issues.
Addressing the whole person, what non-opioid medication strategies were used?
For the burning sensation suggestive of a neuropathic component, either a TCA at the lowest possible dose or gabapentin was recommended. They chose gabapentin starting at 100 milligrams at bedtime and carefully titrating up to 300 milligrams daily based on his creatinine clearance renal function.
Dose adjustment for kidney function. Crucial.
Yes. He was also given clear instructions on the safe use of acetaminophen for his osteoarthritis pain, reminding him to avoid alcohol and stay under the maximum recommended daily dose. 3,000 milligrig a day in his case, considering all sources.
Okay, now what about opioids? His pain was 10-10, severely impacting function despite his fear of addiction. How was that handled?
Given the severity and impact on his sleep, mobility, and ADLs, an opioid was deemed necessary for his persistent pain. A low-dose fentanyl patch, 12 mDHR, was ordered to provide around-the-clock baseline relief, changed every 72 hours.
Fentanyl patch for constant pain. Why that choice?
It provides steady relief, and the patch form might be perceived differently than pills by some patients. Importantly, before starting, a urine toxicology screen was negative, and his opioid risk tool score was low, 210, suggesting lower intrinsic risk for misuse. He also signed an opioid use agreement, documenting discussion of risks, benefits, alternatives, and safety measures.
So careful screening and documentation.
Absolutely. The team communicated realistic expectations. The goal wasn't zero pain, but improved function, mobility, and addressing the psychological stressors, while minimizing misuse risk. For breakthrough pain, immediate release oxycodone 5 milligram every 6 hours as needed was ordered.
Okay, a structured plan. How did the follow-up go? Was the treatment effective?
Yes, the follow-up assessment showed improvement. His pain and functional status were reassessed. With the fentanyl patch and gabapentin, he was using the breakthrough oxycodone mainly just before dressing changes.
That's a good sign.
His pain score came down to a 3 out of 10, which he described as pain he could live with this. He was using acetaminophen PRN for his arthritis and trying it before dressing changes sometimes to avoid the oxycodone. He reported sleeping better and being able to walk further and manage stairs more easily.
Great function improvement.
The breakthrough oxycodone was titrated down to just 5 milligrams taken 30 minutes before dressing changes. He was also started on a compression dressing system as the infection resolved, which is key for healing venous ulcers.
Good. Treating the underlying cause, too.
The psych evaluation found no major depression, and he agreed to join a chronic pain support group, which he found helpful. And importantly, his opioid-induced constipation was proactively treated with Calas, Senna, and Dulcolax as needed.
Managing the side effects, too. A successful outcome overall.
A much better situation, demonstrating that comprehensive, multimodal, patient-centered approach.
The chapter ends with some show what you know questions to check understanding. The first one asks which statement most accurately defines pain. The options are basically variations on definitions.
Right. And the most accurate answer, reflecting the core principle we discussed, is deep pain is whatever the experiencing person says it is. That subjective nature is key.
Okay. The second question asks which best describes the numeric pain intensity scale. Again, different descriptions.
The best description here is typically a 10-centimeter line, or 0-10 number scale, with verbal anchors like no pain at one end and worst possible pain at the other.
Got it. And the final question asks what initial medications are recommended for mild pain according to the WHO analgesic ladder.
According to the ladder's first step, the correct answer is B, non-opioid analgesic with or without an adjuvant medication.
Perfect. Well, that was a really thorough look into the often complex world of wound pain management, all thanks to the deep insights from Wound Care Essentials. It's just so clear that truly understanding and addressing this pain is absolutely vital for helping people heal and, frankly, live better.
It really highlights how multifaceted pain can be, doesn't it? And how utterly crucial it is to listen to the individual's experience, believe them, and tailor the approach. This deep dive is a powerful reminder that effective wound care goes far beyond just treating the physical hole in the patient. It's about understanding and alleviating the often debilitating pain and suffering that goes along with it.
Absolutely. It really makes you think about how vital it is for all of us involved in healthcare in any capacity to genuinely prioritize understanding and managing pain. We need to keep learning, keep asking, keep advocating for the best ways to help those who are suffering from wound pain.
A continuous learning process.
It really is. If you found this deep dive valuable, we definitely encourage you to explore the full chapter in Wound Care Essentials. Practice principles for even more in-depth information and those helpful tables we mentioned. Thank you so much for joining us for this deep dive.